I'm Dr. Adler, and I'm happy to be here. And we're going to be working on cases that are associated often with interesting electrocardiograms. None of the cases are particularly unusual. And by thinking about the history and a careful examination, the electrocardiogram, you will be able to get the answers. We cover every range of cardiovascular medicine. This is a 51-year-old woman. She had the abrupt onset of pleuritic chest discomfort that was worse when she was supine. Worse supine, we know that pericarditis can be worse when people are supine. We also know that ischemia can be worse when someone is supine, although that wouldn't necessarily be pleuritic. She had Hodgkin's disease, stage 2A, 22 years previously, treated with mantle RT and MOP following a splenectomy. She's got treated hypothyroidism as a result of her radiation. She had a soleal DVT 3 years previously, and she has an allergy to contrast. She's not on any medication at all. And her exam shows blood pressure 110/80, 10 millimeter mercury paradox. So it's a little bit of a narrow pulse pressure. Her heart rate's 110. We know that patients who have had previous irradiation have done something to their parasympathetic nervous system. So they may have a more rapid heart rate. Respiratory rate's 20. That seems fast. Her neck veins at the mid-neck level, when she's seated upright, they collapse with inspiration. So they seem like they're a little on the high side, but when she takes in a breath, they definitely go down. Her lungs are clear. She does not have a palpable PMI. And when you can't feel the PMI, of course, somebody can be heavy, but one of the things it makes you think of is a pericardial effusion or very significant myocardial disease. Her carotids, upstrokes are brisk, but the volumes are diminished. We're thinking we're dealing with a poor forward output. She has a normal sounding S1, it's not muffled, a single S2, and she has an early peaking systolic murmur along the lower left sternal border. We don't hear any kind of rub. She doesn't have any peripheral edema. Seems like this has all come on pretty quickly. And here's her electrocardiogram. So we look at this and we say, yeah, okay, we knew there was a rate that was fast. And we're taken right away to say, this is an odd snapshot of the PR interval in lead AVR, where it looks like it's elevated. And then we look at the PR interval in lead 2, and it looks like that's depressed. This tips you off. There are not other things that do this. This is acute pericarditis. And then to figure that out, also, we see other areas where it looks like we have little bits of J-point elevation. But this is a nice tracing because instead of having all the J-point elevation that you're used to seeing, what you wind up seeing is much more in the way of the PR segments. What's also important is when you see ST segment elevation in lead B2, we've discussed already, you could have right heart strain, all right? And conceivably, that could be an anterior issue as well as a posterior issue. So which of the following are true? The pleuritic discomfort against her background of a DVT suggests pulmonary embolism as a possible diagnosis. Could be, okay? She lies back, she feels worse. We don't hear any kind of rub, but pulmonary embolism is possible. Radiation and symptoms in EKG suggest a pericardial processes that could include effusive disease or effusive constrictive disease. And that's possible. She had radiation that could have given her constrictive disease. She's got an acute issue that could give her effusive disease. We don't feel her PMI. Prior radiation and symptoms suggest chronic constrictive pericarditis. She may have some degree of chronic constrictive pericarditis, but these kind of acute symptoms are not what you'd expect with that. Appropriate testing would include ventilation perfusion studies, surface echo Doppler, and that would really make sense. You could learn probably from both. And sure enough, she has a large circumferential pericardial effusion. Now, she doesn't have diastolic collapse of her RV or RA. What's important to know is those are late signs of tamponade. But her transmitral early filling falls 35% with inspiration. So when she takes in a deep breath, she pulls the blood in her lungs. The left atrium is supposed to suck the blood into the left atrium. But if you have a large effusion, you're not going to be able to transmit negative intrathoracic pressure to the left atrium. And therefore, you have this large drop, transmitral inflow. Normally, the fall is 5%. This is 35%. The transtricuspid early filling increases 75% with inspiration. So ordinarily, a person takes in a breath, sure. They increase the size of the great vessels. They increase the size of their right atrium with negative intrathoracic pressure. They increase filling and they increase flow by 15% on the right side. But if it's going up 75%, what that tells you is that during expiration, nothing was happening. So there's a dramatic difference. Nothing goes on in expiration. So there needs to be an enormous increment in inspiration. So both of these things lead you very much towards saying, yeah, this is tamponade physiology. All diastolic pressures between 18 and 20 millimeters of mercury. When you take her to the cath lab, she's got a blunted Y descent in the right atrium. Of course, there's a blunted Y descent. There's no early filling. And a blunted early filling in the right ventricle. So these are all signs of tamponade. So the question is, what is her pericardial pressure? Is it 18 to 20? Well, 18 to 20 would be exactly what all the other diastolic pressures are. And the definition of tamponade is when the pericardial pressure equals or exceeds the right atrial pressure. So you know this is where it is. Is it 0? No, 0 would be normal, okay? Virtually no fluid and a very pliable pericardium. And 5 to 10, you could see in patients where there's sort of a pre-tamponade physiology, but in her case, we know all of her pressures are equalized and she has all the signs, blunted Y descent of tamponade. So that would be the appropriate answer. So EKG changes in acute pericarditis. Everyone's used to diffuse ST segment elevation with upright T waves. Lead AVR may have decreased ST segments. PR segment depression except in lead AVR, which is what we saw in her case. Often the J point to the T wave peak ratio can be greater than 25%. These are a lot of J points. We already saw tracing with large J points. They were Osborn waves, in fact, and no reciprocal changes except in R. And this is important, no reciprocal changes. If you start seeing reciprocal changes, think of ischemia or think of myocarditis. And then they resolve. There's normalization of the PR segments and ST segments, then there's T wave inversion. Ultimately, these resolve. The time course is variable, depends on the effusions. Myocarditis may alter the QRS amplitude. The effusions may alter it. Myocarditis, if the heart's weaker, generating less voltage. Tamponade, especially from a complex effusion, may be accompanied by QRS electrical alternates. This would be something that would be very characteristic of pericarditis. This is a patient who's had cardiac surgery a few days prior, and you see these very large J points, and you see what we mean by a ratio, the J point to the T wave, greater than 25%. We see lead AVR, the PR segment, not as dramatic as what we showed you before, but the STs are down only in this lead, and all the other leads, we have the J points that are up. We'll move to a 21-year-old man. He's had 3 days of intermittent flu-like symptoms. He says it feels like his lungs are burning. And he says the same thing. It's worse supine, but it's non-pleuritic. So it doesn't matter whether he takes in a breath, but it is worse supine. He has a history of mitral valve prolapse, and his father has some vascular disease. So the pulse pressure is good. The heart rate's a little fast for a 21-year-old. Respiratory rate's fine. At the moment, he's pain-free. His neck veins are not up. Carotids are normal. Lungs are clear. He's got a pectus excavatum, a little bit like our person with the mitral valve prolapse before. You may see that about 45% of the time in patients with mitral valve prolapse. Normal sounding S1. There's no click that's heard at this time. Physiologically split S2. Now, if there's no click, and he's had a click before, that makes you think that this is a little bit like the squatting maneuver. This means the LV may be larger than we think. And so we've pushed that click very, very late, potentially. Troponin T is elevated and his CK is elevated. It's kind of on its way down. And here's his EKG 3 years before. And we see everything looks pretty good. You can always find something wrong. You'd say, yes, there's something a little off with the J points in this young, healthy person. And here's the EKG presently when he's complaining of discomfort and lung burning. And we have very impressive J point elevations, okay, in a number of leads. And we also see in lead V1, the ST segments are depressed. We've said V1, that could be RV. V1 can be related to the left main. V1 can be something posteriorly. So if we're thinking this is all pericarditis, we should not see any ST segment alterations here. Posterior forces should be able to pull this up just as much. So this makes us think we're more likely in this young person dealing with a myocarditis, okay? And in fact, here's the MRI where we have this mid-epicardial late gadolinium enhancement, this episode of inflammation. And if we look at the outcomes of acute myocarditis, this was 443 patients, and many come in with chest pain, many come in with shortness of breath, a number have syncope, prodromal symptoms, not at all unusual, fever. Now, a much lower number come in, it's fulminant myocarditis. So their hemodynamics are awful. They're collapsing in front of you. They need a whole bunch of support. This moves you very much away from just a standard viral or idiopathic kind of myocarditis. This moves you into the world of giant cell myocarditis, eosinophilic myocarditis, lymphocytic myocarditis, and then there's a number. Once you start getting into the complicated myocarditis, their EF is already dropped. They have ventricular arrhythmia, that's 18%. So we say that's the complicated group. It's fulminant, really struggling, or their EF is already down and they have arrhythmia. And if you look and see what happens, mortality or heart transplant over the subsequent 5 years, it's in 4.1%, but that's only seen in that group of people who come in with the complex. So overall, it's 4.1%, but the patients who come in uncomplicated, they seem to do just fine. And the patients who come in complicated, that's where you struggle. And so the 1 year ejection fraction, less than 50% in the uncomplicated group, almost all of them recovered. In the complicated group, a completely different story. We're going to move on. And now we have a 55-year-old woman. She has no history of hypertension. And her symptoms are that she's got exertional dyspnea and heart pounding. And her family history is that there was sudden cardiac death in an 18-year-old granddaughter of her father. So we take her very seriously. And she has an echo ejection fraction of 65%. The septal thickness is 2.3. Normally it's 1. The posterior wall is 1.3. That's a pretty impressive ratio, certainly greater than 1.4. And she has a Holter monitor, and she has 8 to 10 beat runs of ventricular tachycardia. The rate's about 170. It's clear-cut AV dissociation. You know it's VT. It's right bundle branch block configuration, so it's coming from the left side, and it's a superior axis configuration, so maybe coming from something a little low on the left side. And here's her electrocardiogram. Well, it's a very dramatic EKG, profound voltage, and marked T-wave changes, and very large septal forces. If we look at lead V2. And so we'd say, yeah, this could fit. We've got the family history. We've got all these other things. This makes us think a lot about a hypertrophic cardiomyopathy. And in fact, on our echo, we do have this very thick septum as had been described to us. So which of the following statements are true? Ventricular ectopy with this EKG, but a good EF, we said it's 65%, can be managed with a beta blocker and reassurance. I know beta blocker is nice, it can calm down ectopy, but no, this is not reassuring at all to have that kind of ventricular ectopy. And bear in mind, we have that family history. This patient has an infiltrative process and should undergo endomyocardial biopsy looking for sarcoid or amyloid. We would say that's a lot of voltage that's appropriate with that kind of thick LV. So it starts moving you away from infiltrative processes that may keep the voltage the same or may lower the voltage. The combination of verapamil and beta blockers may be used to quiet the ectopy, and she can be followed conservatively. You know, verapamil, kind of a good agent that might be good for outflow tract obstruction, not necessarily great for ectopy. Beta blockers, maybe, you may be able to do that, but we're nervous. Can this person really be followed conservatively? She has a lot going on, plus a family history of sudden cardiac death. And this patient has this excellent story for hypertrophic cardiomyopathy. An MRI might be helpful. And the answer is yes, an MRI is helpful because it can help you stratify. So we say when we look at hypertrophic cardiomyopathy, who are we most worried about? Well, people who've had sustained VT, they've already had an arrest. Of course, you're worried about them. Those are people that are getting an ICD. But if you're in the world of primary prevention, where this woman would be, if she has a family history of hypertrophic cardiomyopathy and sudden death, that's a very important risk. Unexplained syncope, haven't dealt with that yet. Multiple repetitive NSVT, that's what she has, that's a problem. Abnormal exercise BP response, that's a worry. That's telling you that as they vasodilate, and often that's in the setting of obstruction, but also LGE greater than 15% of LV mass, that can help you, and a mass of LVH, so that if you have a septum greater than 3 centimeters, hers is 2.3. So if we look at this person, we have enough things here. We say she's kind of in the highest risk. This is where we think of an ICD. And then you move down and you say there are different ways that you could potentially arbitrate things. So if they have end-stage disease, so their LV is poor and the EF has fallen, you're more nervous about them. If they have an apical aneurysm, so they've actually started to hollow things out, you're worried about them. Marked LV outflow tract obstruction, you're more worried about it. You can modify things, tell them to avoid intense competitive sports. Coronary disease is, of course, going to make things worse. The LGE we talked about. The older people, you're probably a little bit less worried about. If they have alcohol septal ablation, you're nervous about them having ectopy. So this is a flow diagram, 500 patients, high-risk patients treated with an ICD. And then 20% of them had an appropriate ICD discharge, okay? So if you compute that, you say, well, that's 5.5% per year. That certainly sounds high, and it is high. So it was 11% per year in the secondary prevention, and it came out at 4% per year in the primary prevention. Both would seem quite high. Whether that number is quite so high, not clear. In the province of Ontario in Canada, 95% of people above 45 years old who have sudden cardiac death undergo an autopsy. And so they're able to look and say, well, what is the actual incidence of sudden cardiac death? It seems lower than what we were seeing there in terms of the ICDs. It seems lower. And of course, the scary thing is 70% of the sudden cardiac death was in previously undiagnosed patients. So when we look at these kinds of numbers, they seem well below the 0.5 to 1% per year. In the autopsy, they had a lot of sick people, 31% with a thickness greater than 3 centimeters, just what you'd expect. Go to a little brief case. This is a man who comes in with chest pain, and he has this EKG, and what we see is very significant ST segment elevations in the inferior leads, as well as apicolaterally. So we say, yeah, okay, so this is an infra-apicolateral event, but we can learn more because we say lead 3 has greater ST elevation than lead 2. So that points you toward the right coronary artery. So we'd say, okay, it seems like a right coronary event, all right? And then we can also learn, we say leads 1 and L, those are really reciprocal. That's reflecting what's going on the high lateral wall. But we look at lead V1, we've said V1 can be the right ventricle. When we look at V2, we say, well, could this be the right ventricle? Easily could be, but what's important is if this was all posterior, then we would expect the ST depression in lead V2 to be the same as the ST elevation in leads 3 and AVF, and it's much less. So that tells us something is pulling up here. And so when we add all this up, we say it's right coronary artery. The fact that we see this and we see this, we say this is a very proximal right. This is an RV. in for a posterior infarct. And in fact, you can see that's exactly what it was, an extremely proximal right coronary artery. This is a 66-year-old man who comes in because acutely in the morning while he was exercising on his treadmill, he had severe anterior chest discomfort. Some of it was in his abdomen, and he also had discomfort in his back. And after he thinks for a little bit, he makes a phone call to his primary care physician after about an hour, and the person says, I really think you should come in. By this time, he's actually starting to feel a little bit better. So he comes in, and he's 71 inches tall, 170 pounds, pretty normal stature. His blood pressure is on the high side. He has a history of a little bit of hypertension. He's got no paradox. It's the same in both arms. His heart rate's 55. He's always had a history of a relatively slow heart rate. His respiratory rate's 18, breathing a little fast. He just cannot get comfortable, and he's diaphoretic. And his carotid upstrokes seem fine. Volumes are okay. His neck veins are flat. His lungs are clear. In his heart exam, normal sounding S1, physiologically split S2. It's not at all muffled. He does not have any murmur of aortic insufficiency. His abdomen's actually soft, though he had pain, and normal upper extremities, distal, lower extremity pulses. And here's his EKG. We know he's always had a relatively slow heart rate. And in fact, he does have a slow heart rate here, it's low 50s. And we really don't see much. This is a blip in terms of the EKG machine. It's not seen in any other line. And he has an echocardiogram because his EKG is unremarkable, saying, well, you know, could there be a wall motion abnormality? And even though we didn't hear any aortic insufficiency, it looks like there is some aortic insufficiency. But what's most important is this is dilatation of his ascending aorta. And if we look closely in here, there is a flap. So what would the next steps be here? So you'd say, should you do posterior leads because he had back pain? We're not seeing anything. Could be a circumflex event. You could, but that's really not the issue based on that echo. Do you do right-sided leads given the flat neck veins? Could be a sign of a right ventricular MI. Well, the neck veins are flat. That takes you away from worrying about an RVMI. We're focused on dissection here. Right-sided leads, if you think it's an RVMI, are not a bad idea. Does this person go to a CT angio with concern for an aortic dissection? Yeah, absolutely. The sooner the better. Do you give antacids for gastroesophageal reflux disease? You know, based on the EKG and the story and the exam, maybe, but not once you see that kind of bedside echo. And goes for a CT scan, and this is where the left coronary takes off. We're looking at the aorta. Here's the right coronary artery. And we move just a little bit above that, and we see a dissection in the aorta. The smaller lumen, more contrast, that's the true lumen. And so we say with the clinical presentations and signs of a type A dissection, depends whether or not the person's had previous cardiac surgery, as you might imagine, but in no previous cardiac surgery, chest pain, abrupt onset, 88%. What's in any kind of pain, 92%, any pulse deficit, 28%. We went out of our way to say that the pulses were all fine. So that's in a minority of cases. A pericardial effusion, you can see at 48%. That's a real worry. Tamponade, 16%. Widest diameter, the ascending aorta, usually it's wide. His was about 4. Okay, it's in the range, doesn't have to be wide. If a person's had previous cardiac surgery, they may have a presentation that's a little more subtle, okay? Still abrupt onset of pain, still could have the same pulse deficit, less likely to have an effusion because there's more scarring there, okay? But they still have an important incidence of tamponade. One of the things we think of, the heritable presentation of thoracic aortic aneurysm and dissection. It seems 10 to 23% at most of type A dissection have a genetic basis that we understand. We often use a 53, sometimes 57 gene panel for aortic dissection. What's important, many are variants of unknown significance without a great deal of evidence. A lot are autosomal dominant. There's some autosomal recessive. There's some that are sex-linked. And some of them, these kind of abnormalities, are associated with dissection, not necessarily aneurysmal dilatation, which would be important. So the genes in the definitive and strong categories, they've been classified in terms of strong evidence for things. So in here you have, the Marfan's disease, you have Loeys-Dietz kinds of things. Okay, you have Ehlers-Danlos. Those things are important and strong. And then many others, it's much harder to know just what to do with. This is a 66-year-old man who comes in and he says that he can have shortness of breath and orthopnea, lower extremity swelling, if he's not cautious. And he says, I pay a real price for just a couple slices of pizza. Now, his brother had a myocardial infarction at the age of 63. And this patient's a little overweight. His lipids have been treated. He has no history of hypertension. So he's giving us this story for very, very little reserve. And 7 years before, he had developed atrial fibrillation following hip surgery. He had undergone a series of cardioversions, none of which stuck. And then 5 years before, he had pulmonary vein isolation because he had struggled with the atrial fibrillation. And then he had relapses a few years before. And now he comes and he's on apixaban because of the AFib. He's on carvedilol, trying to help control ventricular response. He's on lisinopril because he's had this history of the heart failure. He's on diltiazem, also trying to control rate. Furosemide because of the failure type symptoms, and he's on a statin. And on his exam, he's 120/70, so it's a good pulse pressure. His heart rate's 50 to 60, it's irregular. Neck vein's below 7 centimeters of water. Doesn't seem like he's volume overloaded now, at least on the right side. Normal carotid upstrokes and volumes. Variable S1, which is telling you, why is S1 varying? Because there's different RR intervals. He's in AFib, physiologically split S2. P2 is not increased, doesn't seem like it's pulmonary hypertension, at least based on the exam. And so his EKG shows his atrial fibrillation. It's pretty fine, not very coarse at all. He's got a little Q wave in 3, which people are allowed to have, maybe a little Q wave in lead F, though we're never told he had an infarct. He's got a tall R wave in lead V2. You say, well, is that just counterclockwise rotation? Does that reflect some type of posterior event? And he has this rightward axis. And here's his echocardiogram. And what we see, it does look like it's a little sparkly, and it's thick. These walls are thick. And we saw that in lead 2, the R wave was thick. Was that reflective of a hypertrophy in the septum? Maybe. And the echocardiographer is impressed with seeing this kind of wall thickness and seeing that it looks like it's a little sparkly. So the person does strain. And we see that out at the apex, the strain looks like it's pretty good. Negative numbers are better, but toward the base, not very good. And the global longitudinal strain, we like to see something closer to -18, is not what it should be. And there's a real gradient going from base to apex. So next steps, well, you wonder about ischemia that was missed. We talked about the EKG. We've said he's had a lot of failure. So you could think of an exercise echo, but we think this doesn't look like it's in the realm of ischemia from everything we've seen. We're suspecting infiltrative disease based on recurrent atrial fibrillation, poor tolerance of atrial fibrillation, which is very important, the left ventricular hypertrophy. And this is where we say, yeah, let's look for AL amyloid, SPEP, UPEP, serum-free light chains. And if all negative, you could do a technetium pyrophosphate scan looking for TTR amyloid. On the other hand, we say voltage isn't low. Nuclear perfusion studies showed only a fixed defect, no ischemia, just manage the patient's volume. Well, you don't have to have low voltage to have an infiltrative disorder. Thinking about infiltrative disease does not exclude coronary disease. So that's important. We think, well, maybe there is infiltrative disease, but how do we know he doesn't have coronary disease? based on everything that's been going on. And so in this case, the SPEP, UPEP, serum-free lights, all unremarkable. 99.2% of the time, at least one of these would be abnormal if you had AL amyloid. But the technetium pyrophosphate is markedly abnormal, suggestive of TTR amyloid, low voltage, seen less than half the time. The TTR gene in this patient's case was unremarkable, so this is wild type, all right? Sure enough, you work him up for ischemia. You say his exercise echo was positive anteriorly, and he has a severe LAD stenosis. It's stented, and you do get some improvement in his exertional dyspnea. And then he has a stent, and he's embarking on a course of tafamidis. So the message is, yes, infiltrative disease, you're thinking of it, but don't exclude ischemic disease, and you may have to treat both. So you suspect AL amyloid amongst the heart failure population, serum-free light chain abnormal rates, okay, kappa greater than 140, you really think of it, lambda greater than 60. This could go on years ahead of the diagnosis. NT-proBNP can really be up, especially when it's really elevated. Posterior wall thickness greater than 1.3, because so many things can affect the anterior septum. Other helpful findings, any infarct. So this patient, you looked at and said maybe low voltage can be pretty low. RVSP, pulmonary hypertension, stiffness, and then strain that we talked about. We'll move to an 81-year-old man with 3 days of chest discomfort. And he has pain that radiates to his left jaw. He's had gastroesophageal reflux disease and esophageal strictures, and he's had multiple dilatations. He's got diabetes, hypertension, and a long-standing left bundle. And his blood pressure is 147/80. His heart rate's 114, crackles, LVS3, paradoxically split second heart sound. So the crackles tells us increased left-sided filling pressures, LVS3, increased left-sided filling pressures, paradoxically split S2, that fits with what we've been told about his long-standing left bundle branch block. And here's his EKG. So we know he's going to have a left bundle. But what's important in the setting of a left bundle is that the repolarization should be opposite depolarization. So depolarization is down, repolarization is up. Now we see what seems like a lot of ST elevation here, but it's very hard to make too much of that. You could see 5 millimeters of ST elevation, and it doesn't necessarily mean anything. Here, depolarization is up, ST depression is down. Seems very impressive, doesn't necessarily mean anything. But what you're really looking for is concordance. So here, if you see depolarization, which is down, and repolarization is also down, fairly subtle, okay, that is a sign that something is amiss. That's a sign of ischemia. So in this patient, we say he's got a left bundle, his heart rate is rapid, he's going into failure. Can we read anything here? We'd say, yeah, we're worried about something out at his apex. Something is creating trouble. This lead, a little hard to know because it's kind of isoelectric. So we say ischemia based on history, cannot interpret more on the EKG secondary to a left bundle. Well, like we said, you can learn on a left bundle if you have concordance. We say ischemia based on history, mark global ST changes that are significant even with a left bundle. Well, there are global ST changes, but the depolarization is largely opposite the repolarization, and they don't have to be significant. Ischemia based on history and leads V3 and V4 concordant changes. Yes, this is what's making us worried. This patient needs an echo to decide next step. He may simply have GERD, EKG changes consistent with left bundle and tachycardia. Again, the concordant changes take us away from that as an answer. And in fact, he goes to cardiac cath, and he has a severe ramus, and it was his ramus that was involving very much his apical lateral wall. And now we'll look at a patient who has also a left bundle branch block, has had a right cerebral event, quite a long time ago, dyslipidemia, hypertension, has chest pain following a mechanical fall, related left hip fracture, open reduction, internal fixation, all right? And we look at the old EKG. The old EKG in this person with a left bundle, we'd say, well, here's depolarization and here's repolarization. That's all fine. But here's depolarization, here's repolarization. It's not really opposite. And if we look at leads 1 and L, it's definitely not opposite. T waves are upright. T waves are upright. So this is an EKG where we would say, even on the old, even though it's a left bundle branch block, we're worried, is this somebody who has coronary disease? Could this be coronary disease involving the left anterior descending coronary artery? Is this all anterolateral? You know, what exactly would this be? And then this person comes in acutely and they have concordant T waves. Now we see in leads V2 and V3. These T waves look like they're less impressive. They're down, they're a little bit opposite. But these are down, and we say when they're down here, yeah, that could be related to the left anterior descending coronary artery, or are these posterior changes? Is this related to the circumflex? Just what's most important, we think something is likely going on. And in fact, this person had acutely occluded the circumflex. So those reflected posterior changes in leads V1, V2, V3. The LAD had a chronic collateralized occlusion. So you might have suspected that on that old EKG if you had said, why in lead V3, why don't I see depolarization opposite repolarization? Why in leads 1 and L do I see T waves that are up? It may have led you to the LAD previously. This is a 56-year-old woman with a sudden onset of exertional dyspnea and pleuritic discomfort. Now, we've already seen a patient with dyspnea and pleuritic discomfort. Now, this person has had 2 months of intermittent chills. She's a fit runner. She's a busy teacher. She has no history of hypertension, diabetes, elevated lipids. 3 months ago, while she was running, she fell. And she says she fell because she had brief double vision. She had a neck injury. She went to the local emergency department. They tried to place an IV, and she didn't like the whole experience. Then she underwent a head CT. It was a CTA, and it was all fine. They said, you know, we don't have a reason why you had double vision. We think you're fine. But she remembered that ED experience. Subsequently, she just wasn't feeling well, episodic chills. And so this goes on now for a couple months. And on the day of admission, she says she's really short of breath. She's got pleuritic discomfort when supine. In her medical regimen, just on some levothyroxine. And her exam, she's febrile. She has very good pulse pressure. She's tachycardic, especially for somebody fit, although febrile. Respiratory rates increase. Pulse ox is okay. We would think that it would be better. And her neck veins are flat. Her carotid volumes are normal. She's got a systolic murmur that's heard left of the spine near the scapula. Does not have a pectus excavatum. We talked about that with people with mitral valve prolapse. She's got a hyperdynamic precordium. Her PMI is not displaced. And she has a loud S1, physiologically split S2. P2 is not heard at the lower left sternal border. Doesn't seem like it's loud. And she has a 3/6, slightly late systolic murmur. It's heard everywhere, loudest at the apex, also posterior, like we said, you could hear in the back, and it moves minimally later with a hand grip. So it's moving us toward some amount of mitral valve prolapse in this case. So her blood cultures grow strep mitior. Her echo shows thickened mitral valve leaflets, 3+ posteriorly directed mitral regurgitation. So what would the next steps be? She has endocarditis. So IV, then possibly oral antibiotics for 4 to 6 weeks, surgery if she has heart failure or embolic events or recurrent fevers. All sounds pretty reasonable, including the potential for oral antibiotics. Antibiotics, early mitral valve replacement for destroyed valve and large vegetation. And this is really true, okay? If she's destroyed her valve, even if she hasn't gone into heart failure and she has a large vegetation, that's a group that it makes sense to operate on early. Mitral E-clip early with antibiotics, we'd be very nervous about putting a clip on that kind of valve. Early surgery if the valve seems like it can be repaired, otherwise follow conventional indications. And this is if somebody has chronic mitral regurgitation, usually from degenerative disease, nothing to do with endocarditis. And so the study that's important is the E study, and they had the conventional approach operating for fever, embolic events while treatment, hemodynamic compromise, special consideration for staph, fungi. Or in the EASE trial, they said, what about if you destroyed the valve? You have severe AI or MR, and you have a large vegetation, okay? Randomize the people, some surgery for conventional, some for that, and you excluded people who already had a major stroke, hemorrhagic transformation, prosthetic valves, right-sided vegetations. They're all taken out of this, but there was a large difference in embolic events, okay? 8 late versus early. Remember, you're only dealing with about 40 people in each group. And so that's why the answer here is if the valve's destroyed and there's a large vegetation, it's time to operate. In terms of whether or not you can finish the course with oral antibiotics, this was the POET trial. The patients, you see the ages, diabetes, a bunch of them did have a prosthetic valve. You had people who had large vegetations, and a lot of them underwent valve surgery. So now can you finish the course with orals at home? They all got IV antibiotics for a while. You did a TEE, you were cautious with them, you made sure everything was stable, and if it all was day 17 to 19, maybe they would be able to go home on oral antibiotics. They were randomized, and it turned out that you looked for these kinds of events, and when it was all said and done, it looked like the oral group would do okay. So in terms of all-cause mortality, all right, it looked like, in fact, you had a little bit of a difference here. Unplanned cardiac surgery, really no difference. Embolic event, no difference. Relapse of a blood culture, really no difference. So you can go ahead and you could use oral antibiotics in this very, very selective group. One caveat, when we look at antibiotic prophylaxis in 2007, the thought was there was too much of it, so just use it for prosthetic valve shunts, people with prior SDE. Sometimes you add in patients who've had a heart transplant and have highly significant disease. But what happened is there was an upstep in the amount of endocarditis. This was in the UK, and so it's made everybody nervous. So people who have significant valvular disease, you may still want to think about prophylaxing. That represents our last case, and I'd like to thank you all very much for your attention. I hope that you found these cases interesting and worthwhile.